So we talked about this, going all the way back now, to this steps of response. So after you dealt with major bleeding, mainly pressure is key. We'll come on to some specific hemorrhaging later on. The next step is airways. So there's a few ways you can manage an airway, a few different tools, some more gruesome than others, as you can see there. The first one is a nasopharyngeal airway, or an NPA. Basically just a flexible silicone tube. You shove it up their nose, and it assists their airway. Generally not to be used on a patient with a gag reflex that's intact. An NPA, maybe less so than an OPA. You could probably get away with using an NPA on a semi-conscious patient, but it ensures that they have a viable airway for providing some kind of oxygen therapy. So an OPA, an oropharyngeal airway, it's kind of obvious what the difference is between these two. Naso for nose and oro for oral or the mouth. It's a hard plastic tube, and it again opens up the airway to allow some kind of mask to assist breathing. An LMA, it's a laryngeal mask airway. This tube goes down their throat, and it's essentially an inverted mask. So this kind of means you don't actually need to put a mask on them. You can affix breathing mechanism right to the end there. Sometimes these LMAs have a camera on the end to help you locate, to help you position them right. So ETI, or endotracheal intubation. This is essentially how they do this in practice is they have a tool attached to the end of this tube, and it helps guide it in. And then once they get it to the place they want, down the esophagus, they will inflate this cuff. It's basically a little balloon with another tube running up the inside to inflate the balloon. And again, this is obviously only to be used on a completely unconscious patient, someone who can't support their own airway, major trauma, really. The difference between using these two, the naso and oropharyngeal airways, is whether they have possible head injuries. You want to avoid using a nasopharyngeal airway if they have possible skull fractures, for instance. And kind of the other way around for an OPA. So the last step in the airway management ladder is what we call needle cricothyroidotomy. It's a mouthful. Actually, it's a needleful. God, I'm funny. Why is no one laughing? This is the last step in airway management. Usually used if there's major head trauma, and it's essentially allows for a needle to be passed through the cricothyroid. It's this section here, and allows for essentially like a direct injection of air. Extreme cases only. If they can't support their own airway, if they have a head injury, it's pretty much the only cases. Okay, so to pair with your new airway management on your patient, you need to work out whether they need assisted ventilation. If they are breathing okay, but they just can't support their own airway, if they've had a tracheal collapse or something, but they're still breathing okay, which would be unusual, but then you can use what we call a non-rebreather mask, which essentially just passes oxygen through, and it relies on the patient being able to respirate themselves. It just adds oxygenation, so it requires less intensive breathing. If they can't support their own airway and they can't breathe properly, we use assisted ventilation. The most common is what we call a BVM, or bag valve mask, to be used in conjunction with an NPA or OPA, and it's used by operated by an assistant. So if you have a second person with you, essentially you'll stand behind them and you'll squeeze it to inflate and deflate oxygen into their lungs at a rate you deem appropriate. Like we said earlier, somewhere between 12 and 20 breaths per minute is what you want to match. They have to be unconscious, obviously, to use this. I'm not sure if people are keeping up with the ventilation stuff around COVID, but maybe just if I could take on a bit of a tangent here. Lots of people are trying to come up with solutions on how you deal with ventilating patients, and because running out of ventilators and such, and people have come up with mechanisms to just use these with like a robotic arm that squeezes the bag in and out. In practice, for someone who doesn't really understand the process, this sounds fantastic. Sounds like a cheap way to ventilate a patient, but in reality, it doesn't work at all. And it's the same thing with this Parapack, because all of these ventilators are doing is on a timer, they're pushing air in and they're taking air out, and they're pushing air in and they're taking air out. But in practice, these can only operate for somewhere up to an hour before you're really going to start causing barotrauma on the patient. It's going to start injuring their chest and their diaphragm and their rib cage and all the tissue around it. So actual medical long-term ventilators essentially use the patient has to have some kind of breathing, even if it's completely weak, and it will basically kind of know when they're starting to breathe in, and it will push air in when they're just there's kind of a sign of it, and then again when they're breathing out. So it's kind of working with the patient. These are just forcing air in without any kind of regard for whether the patient wants to breathe in or not. Bit of a tangent, but I hope it adds some context to the ventilator situation at the moment. So the other option is, sorry
to interrupt, Alfred. Yo, I need Knight. I need you to come to the admin office. Thank you.
I'm back, Felicia. Yeah.
Yeah, it's the what's it called? Staff meeting.
Oh, I see. Bad timing. My bad.
I'll be back in a sec.
Okay, so the other option is a Parapack. It doesn't require an assistant to operate. It's a similar thing. You can change the tidal range, I think they call it, which is how much you're pushing in, and you can change the frequency as well. So that's assisted ventilation. Does anyone have any questions on these two? That's pretty much the airway, the breathing section covered before we go on to the next stuff. Make sure it is. Yeah. Epic. Let's continue. So, cardiopulmonary resuscitation, or CPR. Ash just sent me a screenshot of her dead on the floor. What is... Is everyone pissing about while I'm trying to teach this? Do I need to come on and get you in order? Get you sat down in a class or something? Okay, so cardiopulmonary resuscitation, or as it's more commonly known, CPR, and BLS, or basic life support. So you start CPR when there is minimal to no breath sounds and there is no sign of a pulse. The usual ratio between compressions and breaths, this changes all the time in the medical world, but pretty much I've just kept with this, is a 30-to-2 compression to breath ratio, 4 to 5 centimeters deep at around 100 per minute. I'm sure you've all heard the staying alive. Has anyone watched The Office? Just on the off chance.
I know the song. I don't watch Office, though.
Oh, there's an absolutely hilarious scene in The Office. Michael's doing basically they do this fire drill, and that they do this kind of bad fire drill, and one of them has a heart attack. Stanley has a heart attack, and they have to do this mandatory CPR training. And he's like, you have to do it to the rhythm of the song. So he goes right from the start. At first, I wasn't, I was petrified. He was doing like one every 20 seconds. Anyway, just a funny tangent. So if you want, if you have assisted ventilation in place already, or if time permits, you can use what we talked about earlier, FiveM and Power Pack to do your rescue breaths. So you don't have to have an assistant. So defibrillation. This is quite an interesting one. Pretty much everyone knows what defibrillation is, but not many people know what exactly causes the need for a defibrillation. Does anyone know? Does anyone know what's actually happening to the heart when you're in a place where you need defibrillation? Ash, not you, because you probably know.
It's shocking it back to life. Shocking
it back to life. Yeah.
Oh, so it pumps again, starts pumping.
Yeah, so that's kind of it. Anyone have any additional knowledge there? What's causing it? So essentially, your heart is made up of this muscle called the myocardium. It's the muscular tissue responsible for generating a heartbeat and pumping blood around your body, and it's triggered by electrical impulses. And usually, the issue is, and the reason you need defibrillation, is those electrical impulses get into a state where they're quivering pointlessly, and the heart is not actually usefully pumping blood around the body. It's just quivering along. If you've ever seen those ECG machines, that show the heartbeat, it'll just be kind of a bobbly line. I've got ECG patterns actually, kind of in this book, but we won't go into that. And it enters a state of what we call ventricular fibrillation, which is, like I said, where those electrical impulses are just random and useless. So essentially what defibrillation is, because you're in a state called ventricular fibrillation, so you're defibrillating, it's, like you said, you're essentially resetting those electrical impulses, and that's exactly what it does. So I guess to put it how you put it, you're restarting the heart. Now, usually it takes place a minute and a half after CPR, and the reason you do this is to pre-oxygenate the bloodstream to promote spontaneous circulation. It improves the efficacy of defibrillation. First, you have to assess for a shockable rhythm. Then, by placing the pads on, you can get an ECG reading and find a shockable rhythm. If shockable rhythm is found, you do the old top, middle, bottom, clear. I'm sure people watch medical shows before or something along those lines. Heard that before.
Okay.
Make sure no one's touching the person besides the person shocking. But even then, they're not touching them. They just got the pads on. And then you deliver the shock. Assess if a rhythm is found. It's called a sinus rhythm. That's a usual rhythm. So if they've got the regular QPRST complex, there's a lot of words I'm saying right now that probably don't make much sense. That usual heartbeat. If they've got that usual heartbeat, then you're good to go. But if not, you carry on CPR, and again, a minute and a half after, try shocking again. Usually 3 times. If they don't have any kind of response, well, you keep doing it essentially until you get to the hospital, and then they'll take over. Okay, so neurological observations. We mentioned AVPU earlier in assessing neurological states, but another one is the GCS, or Glasgow Coma Scale. Again, if anyone's into medical dramas or medical shows, you'll hear them say, he's got a GCS of 8, or something like that. and it's a scale between 3 and 15 that measures consciousness in 3 different areas. We'll go over them in a second, and also the FAST acronym. I'm sure everyone's heard this for recognizing potential strokes. So GCS, the Glasgow Coma Scale, it measures 3 different things: eye-opening response, verbal response, and motor response. They're measured between, well, depending on how many different levels there are for each one. You can this gives you a pretty good overview. You can't have a GCS of less than 3 because the lowest for each of these areas is 1. So obviously can't be less than 3. Again, it adds a bit of realism. If you've got someone who's role playing as a doctor in the hospital, we used to, I don't know if they have any doctors or anything like that, but we used to have doctors that actively did role play in the hospital, and it's a good way to pass over. You can run through the vitals and the GCS and stuff. Does that make sense? Okay, cool. And then FAST for recognizing strokes. So you assess the face. Is the face drooping to one side? Arms. Do they have arm weakness? Now, I'm pretty lanky, so please don't think I'm having a stroke. I'm a weak person. It's just my normal. It's just my normal stature. I'm joking. Arm weakness on one side usually. So speech. They have a difficulty speeching. Again, that kind of is paired with this drooping to one side. And then time to call an ambulance. You are the ambulance. So that doesn't really apply. It's just fast. It's the important bit. There's not much you can do on site to respond to a stroke. I actually don't know much about strokes. Just get into the hospital and say they've suffered a stroke. Ashton, you may be able to add some extra knowledge there. I don't know. Yeah. Yeah. So pain management, it's an important part of your treatment process. And here we go. I'm going to hit you with another acronym. This one's OPQRST: onset, provocation, quality, region, severity, time. Did it develop suddenly or over time? What causes the pain? Or what makes it worse? You can ask, does pressing on your arm make it worse or something? Quality, is it sharp, dull, burning, crushing? Some kind of injuries that could go along with these. If it's a sharp pain in their leg, kind of an indication of a possible broken bone, or it could literally just be a piece of glass in them. I'm sure that would feel pretty sharp. So a dull one could be maybe an internal fracture. I think feeling of having a broken rib is more of like a hard bruising, and sharp, I'm sure it could be a combination of both of those. It's sharp, all right. You have. Yeah. Yeah. So quality, region, where is it, and is it localized? Again, this can help you determine what kind of possible injury it could be. If it's in just one exact place, again, it could be a broken bone, or if it's spread out across their whole body, it could be more of a respiratory or a blood flow related issue. Severity, how bad is the pain? You can use the old how bad's the pain on a scale of 1 to 10 to help you indicate severity and your need to treat. And time, when did it start, or how long did it last, if it's already stopped. Okay, cool. So we can use this pain management matrix to help determine what kind of possible medication we can give. There's a few medications you can give on the field that are useful for the patient. So epinephrine is often, I'm sure you've all heard of EpiPens. It's obviously also given for major allergic reactions, but essentially all it does is increases. It helps promote electrical um, impulses to the heart. So it's obviously more complicated than that, but that's pretty much all you need to know. So morphine, obviously everyone knows what morphine is. Avoid giving it to addicts. Had a few funny role plays with that though. So if you want to do it for the role play, then go ahead. But generally, avoid using morphine as just as a get out solution. It's kind of the disclaimer I would say. Don't just say that they've come in with a broken neck and they can't breathe or something. Say, here's 20 milligrams of morphine, you're fine, off you go. Because they'll probably go along with whatever roleplay you say, and that's just that's not much fun for anyone. So Ativan is an anti-seizure medication. It's also used as a sedation for intubated patients. We mentioned orotracheal intubation earlier. It's a medication you'd give there to stop possible gag reflexes and yeah. So saline. So there's two instances you'd use saline. Well, actually, we'll go through one big one first. So if someone suffers a major hemorrhage, a big bleed, they'll lose a lot of blood, obviously, and their body will start to go into shock to try and counteract that. The way you would deal with minimizing the shock is through saline, and you'd use what we call large bore peripheral IVs into each arm, and it replaces that fluid loss to bring them out of the shock. So that's one way of treating shock. The other way of treating shock is try and keep them warm, give them a warm blanket. That's the first go-to. But if you know what's causing it, if they're major bleeding and then they've gone into shock, you know exactly what to do. So dextrose, we mentioned earlier, for treating hypoglycemia, which is where the blood glucose levels are too low. And then nitroglycerin is another one for treating cardiac arrest and pulmonary edemas, which is another rhythm, ECG rhythm. So gas administration, this is quite a good one because there's not very much you have to remember here. So if you don't take anything away from these medications and when to use them, these two are pretty much the most useful. Entonox, I'm sure everyone knows what this is. It's often called laughing gas. It's a 50-50 mix of oxygen and nitrous oxide. It's a good generalized pain relief for broken legs and such, kind of more minor pain relief. But it makes them giggly, and it can actually be. I like to use this, and I probably use it more than they use it in real life, just because if you go up to a patient and say, I'm gonna give you some Entonox, it's otherwise known as laughing gas, it can make you a bit giggly. It livens up the roleplay and makes it a bit funny if they start laughing or coming up with silly jokes and stuff. And then oxygen therapy, we mentioned hypoxia, hypoxic patients earlier, or again if they're unconscious or unable to support an airway. You'd usually have a tank of oxygen that you'd provide at 100%, depending on their current state. Yeah. So I guess kind of again tying into COVID, if we know how COVID is affecting people, it's building up it's kind of, if your lungs are a sponge, breathe in air and take it out, it's filling that sponge up with liquid and it's minimizing your tidal range. Basically the amount of breath you can take, it makes it more labored. Same thing if you've actually taken in water for drowning patients. So the key is to, like Ash said, make sure their oxygen saturation levels are high enough. You can use that SpO2 meter to measure. Any questions there?
No.
Awesome. Okay, we're almost there. I'm so sorry this is going on much longer than I thought it was. I know this is a massive amount of information. I'll give you the slides so you can digest it in your own time. So, fracture and soft tissue management. So the key goals are to reduce pain using what field pharmacology you know, prevent any further injury. So immobilizing is essentially the key thing there. Ensuring neurological and vascular supply, distal to the injury. So what this means is if they have a broken leg or something, making sure there's no major blood, no major veins or nerves and such that could cause further injury. Reduce the risk of fat embolism. I actually don't remember what that means. So that's not very helpful. I just copied and pasted this bit, to be honest, from my handbook. And then promote recovery. So we'll go into some more specifics. Limb immobilization. There's four main ways you can do this. With a box splint, which is these yellow things down here. Good for majority of fracture cases. Another one is a traction splint. It's slightly more aggressive in terms of repositioning. You'd use this on maybe minor fractures. Use a box splint on bigger fractures where there's possible external bone. A vacuum splint, which kind of wraps around and seals up. It's pretty self-explanatory. And then what we call a SAM sling. So this brings me on to another kind of subtopic is pelvic fractures. So around the waist, you've got your pelvis, and you've got some major arteries and veins that run to your legs that pass right by the pelvic bones. If you fracture your pelvis, one of the worst things that happen would be that your pelvis can break one of those veins or arteries, and you'll have a major internal bleed, which would result, like we said earlier, you'd probably die from blood loss in about 5 minutes. So the key there is to use a SAM sling to essentially try and just squeeze it back together to prevent any movement of the pelvis during transport, to reduce the risk of possible arterial, internal arterial cuts. Okay, we're almost there, I promise. So spine immobilization. This is a big one, and something you'll probably want to do straight away is immobilizing what we call the C-spine or cervical spine. You can do this by holding your hands either side of their head to start, and then later on you can apply a C-collar, which is this thing here. I'm sure you've all seen one of these before. For lower spinal injuries, you can use a spinal board. Generally less used now in the medical world. They're quite aggressive, but they can be used for immobilization. The other one is vacuum mattresses, similar to vacuum splints. They just kind of inflate around the patient to try and immobilize them. You might see these in air transport, so I'm sure as Coast Guard you might be using these a bit more. Yeah, so that's essentially a spinal board, isn't it? Okay. So internal bleeding, the key things are it's hard to spot, it's hard to stop, indicated by bruising or going into shock, like we mentioned earlier. Major hemorrhaging leads to shock. There's absolutely nothing you can do about internal bleeding on site. It has to be done surgically, so getting them to the hospital ASAP is key. So spotting it is an important step regardless of whether you can treat it or not. Like I said, major bleeding, major bruising is an indicator. But yeah, like we also said, losing a lot of blood makes your body go into shock, so it's a good indicator also. So a way you can classify wounds, you've got kind of 7 major sections here. I used to remember an acronym, BTLS, something or other. Bruises, lacerations, tenderness, swelling. Yeah, anyway, you can see them all here. And it's kind of a good way to decide how you're going to treat them. Incised wounds, often by, shards of glass if they've gone through a window or a knife, is kind of like a knife, a typical clean cut is what you'd say. If any major arteries or veins have been cut, major pressure and tourniquet and cleaning and sealing the wound. Again, with the hospital is the key. A laceration is essentially just a it's like a tear. So it's kind of a I don't really know how to describe it. It's a fast action that causes a tear in the flesh. Punctures or penetrations, pretty obvious. Gunshot wounds, GSWs, knife stabbings. I'm sure you'll see a lot of those. Abrasions. So if they've gone off the roads, fancy name for road rash in most cases, but any abrasion where it's like sandpaper kind of effect. Crushing, self-explanatory. Bite wounds from dogs or could be people. Who knows? Who the fuck knows? City's crazy, man. Again, bite wounds, the key there is to clean it. And contusions is a fancy name for bruising. Again, bruising indicator of an internal bleed. Little you can do about it on site, depending on how major it is. Use that to determine your state of urgency to get back to the hospital. So just in general, wound control is reassure the patient, elevate the wound, expose and identify the wound, apply direct pressure, and apply clean, sterile bandaging. That's kind of a good rule of thumb. So the next one's burns. Pretty obvious first step, remove the source of the burn. Then cool the burn using regular temperature water. Obviously, using ice just is not going to help. It'll probably do more harm than good. Just cool, unclean water and then cover and clean it with sterile dressing. The biggest issue with burns, besides it being absolutely excruciating, probably the most excruciating kind of injury you can get, depending on how bad it is the risk of infection. If it's covering a large part of an arm, for example, the amount of potential surface area you've got for infection is so much higher than any other injury. So making sure it's clean is the key thing there. So this is the last slide, I think. Yep. Lung injuries. So we've got two here. Traumatic pneumothorax and a tension pneumothorax. So a traumatic pneumothorax is where the lung has been punctured externally. So if they've been stabbed in the chest or they've been shot in the chest, that's what we call a traumatic pneumothorax. And then maybe I wouldn't say more commonly, but another one you've got is a tension pneumothorax. This is where the lung has been punctured internally, usually by a rib, a broken rib. So look for bruising or movement in the rib. And this is potentially a lot more dangerous because it's harder to spot. But the risk is, if you puncture a lung internally, is that it will build up an absolutely serious amount of pressure. It's kind of like a non-return valve. So you'll every time you breathe in, you'll be building up this pressure, and it will cause a serious amount of damage to the tissue surrounding the lung, the diaphragm. And another indicator you can see in this picture here is what we call tracheal shift or tracheal deviation, where the trachea is to one side. The way you treat a traumatic pneumothorax first, we'll go through, is you use what we call an occlusive dressing. It's essentially just an airtight dressing. You cover it, tape it on all four sides. There was kind of some questions over this. Lots of some people say tape it on three sides and then it acts as like some kind of vent, but usually the consensus is tape it on all four sides to seal the wound completely. tension pneumothorax.
You use a needle, not like a needle, like this little thing, and it relieves the pressure once you push it in there.
There you go. Yeah, exactly. So it is literally just a needle. That's what they use. It's just a large bore needle, usually 14 gauge, and you just inject. You press it between. So between each of your lungs, if you feel, but between each of your ribs, you'll feel you have a space. These are called intercostal spaces. So usually, and you have different axes along your rib cage. There's kind of a bit of a deviation, but you've got what we call the mid-clavicular line. You'll want to go between the third and fifth intercostal space on the mid-clavicular line for a needle decompression. So you stick the needle in. Essentially, all you need to know: stick the needle in their lung. It decompresses the pressure. That's how you treat tension pneumothorax. And breathe. Ironically, we just passed the lung injuries part, but that's it. I absolutely appreciate that was a very serious amount of knowledge all at once. And like I said, I don't expect you to know this and apply it straight away. I'll be putting together a Coast Guard medical handbook, which will be based 100% on this set of slides I've given you today. It adds a bit of extra insight, and hopefully can add some extra context and help remind you to go over these areas. But does anyone have any questions on possible injuries you think I've missed and you want to know how to treat them?
Bullet wounds.
Yeah, so gunshot wounds. Gunshot wounds or GSWs. We mentioned just on the last slide here. So if they're shot in the chest area, you'll cause a traumatic pneumothorax, or it's often called a sucking chest wound because it makes a sucking noise and often blood kind of splurts out when they inhale and exhale. Using occlusive dressing, that's how you treat it. If it's anywhere else, if it's in their lower chest region, below the ribs and below the lungs, just direct pressure. That's all you can do. The worry there is that you hit some kind of intestine, which can cause internal infection. It's a big risk. So direct pressure, that's all you can do with gauze. And again, if it's a limb, we covered this. If it's a limb, using a tourniquet to apply direct pressure to the wound. Pretty much the key is pressure, unless it's a chest wound. If it's a Yep, no, that pretty much covers it. Does that answer your question?
Yep.
Fantabby dozy. Anyone else? Any other injuries you're interested in knowing how to treat, or something that wasn't particularly clear? Alrighty. Well, that's all good. I'm going to assume that means everyone remembered 100%. No, I'm joking. We'll come on to some form of assessment now. So I guess we're going to change up how we originally wanted to do this. I think what we'll do first... Does everyone have around another 20 minutes or so?
Yep.
Okay. Well, let me get my game going again. Hopefully now I'm not streaming. It should connect okay.
I'll be in my head for a sec.